Hi, this is Mike Miller. I'm here with Phyllis Greenberger, President and CEO of the Society for Women's Health Research, to talk about women's health research and how it's changing in the last 20 years and going to change in the future. The Society for Women's Health Research is an organization that promotes transforming women's health through science, advocacy, and education. Phyllis, thanks for being here today.
Thank you. Oh, my pleasure.
You know, one of the things that's really changing currently is this whole concept of comparative effectiveness research. And I want to talk to you about how it's changing women's health research and changing clinical medicine. Can you tell us about clinical effectiveness research and what your thoughts are on it?
Well, I'd like to think that that CER, Comparative Effectiveness Research, would actually help women's health and women's health research. Our basic problem is that depending upon how they look at the research and what research is looked at, whether there's information there that really applies to women. Since even though we've been around now for over 20 years and pushing the whole importance of sex differences and understanding what that means for diagnosis and prevention, a lot of the research is not, first of all, has not included women, for starters, and the fact that we've been doing this for 20 years, people who know research know it takes a long time to get from basic science to clinical care. So while we've recognized a lot of differences in a lot of diseases, we don't know what that means yet. And so our concern is what's the research that they're going to be looking at to make the determination of what works better for whom. And then, of course, there are all these other issues like age and comorbidities, etc. So I just think, I hate to be too sort of pessimistic, but I just think that's an awfully big question. I don't see how they're going to solve it too easily. So we're cautiously optimistic, but I just don't see where they're going to get the research that really applies to women. They're going to be able to make those decisions that's going to be useful.
In clinical care, yeah.
In clinical care.
You think the promise is there, but sort of people's hopes are maybe ahead of where we are at the current point?
Well, look, everybody wants to know what works.
Right.
And I do think that it's clear that there are certain things that work better than others, and we are getting more research on certain diagnostics or certain medications that don't work or have side effects. So, and so I think that's important. The question is how far that can go, and taking into effect all the variabilities, as I said, both sex and age. And the doctor themselves, he or she, how much they've kept up with the latest research, which is a big issue too.
Absolutely.
So and then we're not supposed to talk about it, but it is about money. It's not supposed to be about money, but I think to some extent, and I understand that. I mean, if something is more effective, then presumably you will save money. But then if you're going to only use one or two, let's say, treatments because they're less expensive and may work as well, that may not work as well for that particular individual. So I think it's very complicated. I mean, it is very complicated. Right. I'm not sure that I'll be alive to see how it all comes out in the end, but hopefully it'll come out positively and it'll be helpful.
Well, things are continuing to get better. I mean, the society was formed in 1990, and clearly the research is different now than it was back then. I mean, looking back, when you started the society in 1990, could you imagine that research in women's health would be where it is today?
No, I think this is very exciting.
Is it where you would hoped it would be?
Yeah,
today?
It is where I hoped. I mean, the fact that this is it's international. We established the Organization for the Study of Sex Differences about 6 years ago, and we had an annual meeting. One of the annual meetings was 2 years ago, which was international, and we had people coming in from all over the world. It really is interesting. The problem is that there aren't that many researchers that are really looking at sex differences, and a lot of them, because of their training, clinical as well as doctoral training, really haven't been educated, and that's another problem about the curriculum in medical schools. And so there's, we have what we have is a lot of questions and a lot of recognition of differences, everything from, not only in diseases, but in organs. So in differences in the lungs, in the brain, in the bones, in the heart. But what does that mean?
Yeah, absolutely.
So we can identify these differences, but we don't know what that means in terms of prevention and treatment. And maybe it doesn't mean anything. Maybe even though your bones are different, you can be treated the same way. But we see there are different fracture rates, different places where women get fractures. I mean, there's a lot of differences that nobody looked at. 20 years is not, I guess not.
Yeah.
It seems like a long time because
long.
I've been doing this for 20 years. But in the history of medicine, it's a very short.
It's a long time. I was doing research on bone growth factors 20 years ago.
Yeah.
There were 5 of them. Now there's probably 500.
Right.
So
But did they look at men and women separately?
I know, at least not in my lab.
Okay.
But another major difference between 1990 and today is health information technology.
Right.
Both electronic medical records and now smartphones and the apps and all that. It's really changing how clinicians and researchers and patients are using data, collecting data. Can you talk more about how the implications of that for women's research and where you think that's going in the future?
Well, I think for everybody, it's an amazing transformation. I think there are a lot of questions. So my understanding in terms of medical records is that that's still sort of at the very beginning. That, let's say, Kaiser may have electronic medical records. So if you go to 3 doctors at Kaiser, they can pull it up and they can see, what medications you're on. But if you see a doctor at Kaiser and then you go see a doctor someplace else, or you're a private physician, they're not connected. So we've got a long way to go, the connectivity. And what I've been told is that a lot of the data, companies that are putting together these electronic records in hospitals and throughout are not putting in the analytics and the codes that doctors can use. So that there's been a lot of money spent to actually have sort of the electronics set up, but it's not that usable yet.
Right.
So that takes care of the electronic medical records part, sort of. The other is the apps. There's thousands of them now. So do they work? Do people use them? How do they use them? One of the things that we're doing is we're working with Verizon, and we have proposals from a number of universities and several more that are going to be funded using electronic records and apps and iPads, and Verizon is providing all this to see, in fact, does that work better than just telling someone that this is what you have to do, or giving them a sheet of paper, or giving them a pamphlet to say, do 1, 2, and 3. So on the one hand, there's lots of stuff out there. Do they work? And do they work better than the old-fashioned way?
Right.
And so I think at some point, I'm sure some of them do, and there's some fabulous things, not from the patient, although, this is sort of helping patients adhere, but there's some amazing electronics or apps that doctors are using that can monitor your blood pressure, and that I think is extraordinary, so that you don't have to come in to actually see the doctor. They can monitor some of these vital signs electronically, and I think that's
from home.
From home.
And interconnecting all those things so that people can understand what's going and it's useful. I know that's a challenge that lots of people are working on. So, I saw on your website that you've got this meeting coming up July 18th and 19th.
Yes.
I don't want to get the name right. What a difference an X makes, the state of women's health research. Can you give us any previews as to what that's
Well, this is our annual
happen?
Meeting, and obviously what a difference an X makes is sex, S-E-X-X, the double X, which is for female, biological female. This is a little bit different than what we've done in the past. In the past, we've had presentations on, sex difference in cardiovascular, sex differences in autoimmune. This is trying to sort of integrate various conditions and how they affect each other. So stress and how stress may accelerate or affect cardiovascular disease. And how that may produce, depression. And sort of an interplay of different conditions, looking at the sex differences though, but not looking at each individual disease or condition by itself, because most conditions do not stand alone, at least not ultimately.
Right.
I mean, you may get something when you're at a certain age, but by the time you're 10 or 20 years later, you could be suffering from 4 chronic conditions or more. And so, I think the new way of, at least what people are talking about, I just went to, is not to try to treat each individual disease, but to look at the total person and the different conditions and how they affect each other, which also obviously has implication for medications and whether they interact or how they work together. That's another whole.
You're describing that whole new concept of patient-centric care,
right.
Which, as I've said to some other people, if we want to do patient-centric care now, what have we been doing in the past?
Right.
So that's a whole other question we'll talk about later.
Looking at each disease separately, and you really can't do that.
Yeah. And for clinicians, it's important to look at the whole treat the patient, not the disease.
And we now know that there are conditions that, as I said, cardiovascular into depression and stress into cardiovascular,
absolutely,
that affect one another. So you can't. I think if getting back to electronic records, if that's another problem, is now people see different doctors, give them different prescriptions. They don't know what others doing, and so if we could actually get to this sort of holistic model, and I think maybe a lot of these, I think if you're taking more than 4 medications, you're having interactions that probably are hurting you more than they're helping you. But nobody's really, overseeing that. And then for women, we don't even know what those medications are doing.
Because nobody's looked at some of those specific interactions.
Right. And we do know that women metabolize differently, they have more fat, and that so medications can actually have different side effects for women, or work differently, or not work at all, or even be harmful, we have found.
Right.
So that's another one.
No, it's all good stuff.
Right.
Well, Phyllis, thank you for taking the time. You clearly have done some great work in the last 23 years, and I'm sure you and the Society continue to do good things and keep asking these important questions, which clearly we get answers, and I think in healthcare, the more answers we get, it opens up more questions to keep asking. So thank you. This is Mike Miller on behalf of myself and Phyllis Greenberger. Thank you for watching, and be well. Thanks,
Thank you.
Phyllis.
It's been a pleasure.